Welcome to the Endo Kids Podcast, the podcast where we help families navigate the ups and downs and in-betweens of growing up healthy. I'm Dr. Rinku Mehra, the founder of Endo Kids Concierge and a pediatric endocrinologist, and my co-host is Dr. Lindsey Waldman, who is also a board-certified pediatric endocrinologist. We are here to break down the science of hormones, share real stories, and answer the questions parents wonder about the most. So whether you're worried about growth, puberty, thyroid, or just want to understand your child's development a little bit better, you're in the right place. We believe every family deserves answers, support, and a caring partner in their health journey. So grab a cup of coffee, get comfortable, and let's tackle this topic together today. This podcast is for educational purposes only and is not a substitute for medical advice. Please consult your child's healthcare provider for individualized care. Welcome to the Endo Kids Podcast. I'm Dr. Rinku Mehra, a pediatric endocrinologist and founder of Endo Kids Concierge, and joining me today is Dr. Waldman, who is part of our pediatric endocrine team. Today's topic is going to be congenital adrenal hyperplasia, or CAH. We are going to be breaking down this rare diagnosis, how it presents, and what management looks like, so parents have a clear, practical understanding of this condition.
Absolutely. So let's just say you get a phone call. You just had a baby and you find out that the newborn screen is abnormal. One of parents' worst nightmares, to be very honest. You go to the pediatrician, get some repeat blood work, and you hear a diagnosis that you've never heard before: congenital adrenal hyperplasia, or C if we want to abbreviate it. Suddenly you feel overwhelmed. Well, today we're going to try to make this as simple and clear as possible. And most important, we want to make sure you know that this condition is manageable. You need a team of doctors with a pediatric endocrinologist heading that team, but your child is going to be healthy. They're going to thrive. You are going to do well. We want to break down what this means for you. CAH might sound very complex, but with the right plan, kids do extremely well.
Yeah, and so, let's take a step back and talk a little bit about the newborn screen. So, when your baby is born, usually the baby in the nursery gets their heel pricked, and there's lots of tests that are evaluated at that time. Okay. From a pediatric endocrinology perspective, the ones that we usually see kids for are hypothyroidism. So babies who are diagnosed with hypothyroidism or are born without a thyroid, or this condition that we're going to talk about today, which is congenital adrenal hyperplasia. And that's usually when that diagnosis comes to play. And so let's talk a little bit about what is CAH. So congenital adrenal hyperplasia. This is a genetic condition. Okay. So babies are born with this. It is not anything anyone did to make this happen, but it is something that a child is born with. And it's very important to catch this diagnosis very early, which is why these children are picked up in the newborn screen period. Okay. It does affect the adrenal glands. And like we talked about before, the adrenal glands are glands that sit above the kidneys and they make hormones. The adrenal glands make cortisol, which is a stress hormone. They make aldosterone, which is another hormone that's important for salt balance. And they make what we call androgens, or the hormones that are involved oftentimes in puberty to make kids have hair under their arms or body odor, acne, and also pubic hair. And so they do make these hormones. And in congenital adrenal hyperplasia, there's multiple different types of congenital adrenal hyperplasia, but there is a blockage in how these hormones are made. Okay, so what happens is oftentimes in the most common type of congenital adrenal hyperplasia, there is a low cortisol. So cortisol is a stress hormone that helps us maintain our blood pressure, helps us maintain our heart rate, helps us with blood sugar control, and with salt balance as well. And in this condition, there is a low cortisol. Sometimes the aldosterone level, which is also, controls the salt balance, is also low. And then the androgen levels, okay, so hormones like testosterone are actually high. They can be high in this condition. So it's not one hormone problem. It is a hormone imbalance. And Dr. Waldman, you can talk to us a little bit about why this condition happens.
Sure. So, just like you said, it is a genetic condition. It is not something that anyone did to cause this. And that's really important to remember. It is a mutation in the genes that causes this. And just like you said, there are many different types of congenital adrenal hyperplasia. Today, we're really going to be focusing on the most common classic congenital adrenal hyperplasia caused by a 21 hydroxylase deficiency. Now, that is a mouthful. We know that that is a mouthful. There is a really complicated process to make all of these hormones in the adrenal glands. We had to memorize all of these hormones and all of the enzymes responsible for making these hormones when we were studying to become pediatric endocrinologists. And so it's really important that you work with one of us, someone who knows how to make how all of these hormones are made when you are worried about your child. Just like you said, there is a block in the production of some of these hormones. So because there is a block, some of the other hormones are kind of shifted to another place. So making aldosterone, and because there is still some of these hormones from the very beginning, they get downshifted and make an excess of androgens or testosterone. So the production, there is a shift in production, so to say, and we will see these changes in hormones. Like I said before, there are different types of CAH, the most common being this classic CAH where we diagnose it early. It can be very, very serious, life threatening if it is not diagnosed properly or treated properly. There is a salt wasting type where the sodium is low. And again, this can be very life threatening. And then on the other hand, there is a non classic CAH that is milder and often diagnosed later on. Sometimes when kids start puberty a little bit early, or even later on in the 20s or 30s.
Yeah, and interestingly, I've had patients who have had the later onset form or the non-classic CAH, so they don't have salt wasting, and they come to us for early puberty. And some of these patients that I've seen, actually some girls, have been misdiagnosed with having polycystic ovarian syndrome when actually they have a milder non-classic CAH. And it's important to recognize that because the treatment is sometimes different. I mean, it can be similar as far as the treatment, but just important to recognize that this is a inherited form. And so when those girls get pregnant, they can pass on this genetic condition to their babies. But the non-classic CAH form is a little bit more tricky to diagnose. And sometimes it will take a little bit longer. So the classic CAH that Dr. Waldman was talking about, really often diagnosed in the newborn nursery or shortly thereafter. Okay, and can be urgent and needs treatment right away. And the way it presents, so classic CAH usually is seen in newborns. They can have poor feeding, vomiting, dehydration because they have salt wasting. Okay, so their adrenal glands are not able to make those hormones, cortisol and aldosterone, and so they end up wasting salt. Okay, and not eating well and vomiting. Girls, we often see in the nursery with differences in how their genitals are developed. Okay, because CAH is a condition where we don't have enough cortisol, we have low levels of aldosterone, and then we have overproduction of androgens or testosterone. And boys and girls both have the capability to make testosterone and estrogen. And in CAH, what we see is that there's an overproduction of testosterone in both genders. And in girls, we really see the effect on their genitals because of that testosterone effect. Boys can look normal in the newborn period, okay, because they already make testosterone, and increased testosterone doesn't change how their genitals look. And oftentimes in boys, that diagnosis can be delayed if it's not picked up in the newborn nursery. So that's really important. And that's why when your baby's born, they're often checked by the pediatrician there for their full exam, including the genital exam, and their blood sugar is tested. and they're monitored pretty closely just to make sure that there's nothing else that's going to be missed. And then in children, so children who do not have salt wasting or the non-classic form can have rapid growth early. They can have early puberty signs, and they can show signs of increased pubic hair or acne. And so those are things that we evaluate for. And then in teens, like I said, teens can have irregular periods, excess hair, and acne as well. And that's the typical presentation that we will see and often get blood work for.
When we think about these diagnoses, we want to think about how we come up with it, right? So, like we said earlier, you might get a phone call from your pediatrician or maybe in the nursery that the newborn screen is abnormal. Well, the newborn screen is only a screen. It is wonderful, it is fabulous, it is life saving, but it is only a screen. And so you might have some false positives. And that is why the next step is always doing blood work. And in order to test for this specific diagnosis of congenital adrenal hyperplasia, what we would test for in the blood would be something called 17 hydroxyprogesterone. We would test the child's electrolytes, so sodium, potassium, looking at that salt water balance. And then sometimes we would also do genetic testing. That might be the first thing that happens, but it also might be the second thing after some of those other tests come back. Early diagnosis changes outcomes dramatically. Like I said, this is a life threatening condition if it is not picked up. And so following up on an abnormal newborn screen is extremely important. These tests are also the ones that would be used if we are evaluating a child later on for non classic, whether it is a teen who might have like a PCOS type picture with irregular periods, or a child who is having early puberty with pubic hair, increased growth, we would be checking the same type of blood work.
Right. And then, let's talk a little bit about treatment. So, treatment really does replace what's missing. So, the hydrocortisone, which is a steroid, does replace the cortisol. So, I get questions often from parents saying, why would we give our child steroids? Well, it's really because your child's not making it. So, the hydrocortisone replaces the cortisol. And there's another hormone called fludrocortisone or Flornef, which supports the salt balance. Not every child needs it, but that's often added in, again, because there's a deficiency in the aldosterone and that is needed. And then some babies need salt supplements because breast milk is very low in salt, as is formula. And so some babies will need salt supplements, which they often outgrow when they get to be toddlers or older children. But, really important to evaluate and treat these children. And oftentimes what we find is that once we replace the hydrocortisone and the fludrocortisone and then the salt, that there is more of a balance in some of the hormone levels. And we test for that as well.
Yes. And so when you're following with your pediatric endocrinologist, they will be monitoring your child's growth in height, in weight, again, from the newborn period all the way through to early adulthood. They will be monitoring blood work. So looking at all of those hormones in the blood and finding that balance, which is really, really hard. Looking at bone ages also. So as your child gets older, we want to make sure that they have the best growth potential, and so looking at bone ages is another important piece of the puzzle. And the other thing that they'll do that your pediatric endocrinologist will do is talking about times of stress. So just like Dr. Mehra said, we are giving hydrocortisone, we are giving back what the body is not making. And our bodies make increased cortisol in times of stress. So if you are sick with a cold, if you're in the ICU, you need to keep your blood pressure up. That is very, very important. And with CAH cannot do that on their own. So they will need increased doses of that hydrocortisone, whether it is increased oral doses or in times of stress in an acute illness, sometimes even injections. And so that is a plan that you will come up with your pediatric endocrinologist that we do all the time, talking about those emergency situations and making sure that you're prepared for all of them.
Yeah. And I will say something about stress. This is not the stress of an exam or the common cold, but this is stress like in times when you think of, that your body is trying to fight off an infection or breaks a bone. So usually I tell my patients if you have a fever over 101 or you're in the hospital with a fracture or broken bone, that's the time when you want to stress dose. And really it's very critical because your child's body can't do that on their own. So really important. And then the other thing I just wanted to mention is that, the medication timing really matters. So we often talk to our patients about the timing of the medications, how often to give it, twice a day, three times a day, how often to give it. And we will monitor. So really, being prepared in advance is super important. But most of these children live long, healthy lives and do very well otherwise with proper treatment and guidance. And there's a lot of new medications that are available now that make that a little bit easier as well. So, kids live normal, healthy, active lives. They do everything that every other child, they just need to be prepared in times of emergency. And then they may need to make sure that that you have the medication for your child. So if you're worried that your child has CAH, you're worried about symptoms, you really don't have to navigate this alone. At Endo Kids Concierge, we focus on education, monitoring, long-term planning, and it's really about giving your child the best possible outcome, and that's really what we want for your child. Dr. Waldman, any last words that you have?
No, just like you said, we love working with our patients. And even if you already have a diagnosis of CAH and you are looking for other opinions or other people to follow your children, we are more than happy to go along, to be part of that ride, to be on your team, to be on your child's team so that we can help you get the best outcomes possible.
Yes, and getting a proper evaluation and guidance can make a significant difference. So if you have any other questions, please let us know. But thanks for listening to the Endo Kids podcast, and we will see you next time.
Thank you so much for joining us on the Endo Kids podcast. We hope you're leaving with a little more knowledge and a lot more confidence. If you have questions, stories, or topics you'd love us to cover, please send them our way. We love hearing from you. And don't forget to check out our website, www.endokidsconcierge.com, for free resources, guides, and more ways to connect. You're not alone on this journey. We're here to support you and your family every step of the way. If you enjoyed this episode, don't forget to subscribe to our podcast so you never miss an update.